when we consider the PTSR subject, so we come to we will think comes in our mind that there is a good medicines for gynecological disorders like Shweta Pradara, Rakta Pradara, uterine fibroids, PCOD, many lifestyle disorders, and even the Arbuda and Granthi also. But there is a limited practice in obstetric part because iron, calcium, regular visits, regular checkups, and the complications happening during the pregnant condition. So, as a practitioner, twice we think to prescribe any medicine to a pregnant lady. So, that is why now today my aim is to simplify the things where you can extensively practice Ayurveda, adopt Ayurveda in your OPD level practices. As a general, challenges faced at the OPD levels. Why the PTSR subject is not practiced extensively in the OPD levels? Because it demands for the time for the proper history taking, where because of the rush and the load of the OPDs, many people they fail to give time for history taking. They refer the cases to the higher centers, convincing the couple for various investigation, because as we know, if we go for the general practice, we have to think about the economic status of the couple or the patients also. Considering their economic status, usually we avoid to write the investigations, and we make them to take some of the medicines, that too in a lower cost. So when once we think about the cost effectiveness, there is problem in the PTSR subject, because the PTSR subject demands for various investigations to start the protocol and to give a better result to a couple. So that is why it is the problem faced at the OPD levels. And the arrangements for private examinations. When we, it is a very important thing where most of the OPD fail to give proper justice to the PTSR patients, where we need a private room for the examinations, the light source, and a nursing staff must be there, because as a rule, we cannot, especially a male gynecologist, cannot examine a female patient in a private room single. So he needs definitely a female assistant. Either she may be a nursing staff or she may be a trainee or a student. So she must be there in the private examination room. So here in our OPDs, we definitely we don't have such opportunity for the private examinations. So there we fail to practice the PTSR things in our day-to-day practice. And the proper questionnaires to couple for time saving in OPD. As we know, if it is an infertile couple, if it is a Shweta Pradara couple, if it is a patient suffering from Rakta Pradara, if a patient suffering from any pregnancy complications, so that time asking questions to a lady, okay, asking questions to that lady or a patient to get a proper interaction. So there we fail to ask pinpointed questions. If we ask more and more questions, there is a loss of time in our OPDs, because if you are running a specialized OPD or if I am running a PTSR OPD, for me, I will be giving minimum half an hour to one patient, okay, because it is a specialized practice. But in a OPD level general practice, we give less time to take the proper history. So that is why we need to prepare such a questionnaires. So a single question, you have to get a maximum information from the patient. So like that, questionnaires should be prepared, so that will come with your timely experience. So that is why in OPD level that such proper questionnaires lacuna is there, and timely referral to higher centers with the follow-up of transport protocols. So why I added this point is referring a case is not only important. Okay? you have to follow some protocols during transport of the patient. If patient is in labor, if patient is in PPH, if patient is in PIH, if patient is in so many other complications. So according to disorders, we have a transport protocols. Compulsorily, if it is a PIH, a doctor should be there during the referral in the ambulance, and the nursing staff should be there, and all medicines should be present, and connected medicines. You have to transport the patient to higher center, transfer the patient to the senior gynecologist who is going to treat her in future. Then you can come back to your OPD. So just only writing a letter and sending with the patient is not sufficient in most of the cases where we face medico legal issues. That is why timely referral is very important. Then finally, there is a more problem where case sheet recording. So all of us, mostly we don't maintain the case sheets properly in our OPDs. If you write prescription, nothing, no history in the OPD case sheet, then once the patient come back again for the follow-up, that time we need to ask the history from starting point. Or if patient comes follow-up for after 3 months, 6 months, then we have to start again the history taking from beginning point. So that is why my sincere suggestion is to maintain the case record properly. If patient cannot maintain that case sheet, you have to maintain the case sheet in your OPDs whenever the patient comes with the OPD number or with a special markings, barcode. So anything you can follow in your OPDs to get the proper recording. Okay. So if you get the proper previous history, then we can have more and more pinpointed or accurate treatment, and we can reduce their costs for investigation, unnecessary investigations, unnecessary medicines, and unnecessary other interventions. If the previous history is there, accordingly we can go to the next step of treatment. So that is why case sheet recording is very important. So now let us have a breakup, two sessions, one in the antenatal and the obstetric protocols, and another one only for the gynecology, where we are going to highlight more and more about the infertility management, which is the bread and butter of my practice. So now coming to the evidence-based protocols in antenatal care through Ayurveda. So most of my presentation contain integrate clinical approaches because it is a surgical subject where I need to add modern protocol also. So the first case where the patient, a couple with a history of 4 spontaneous first trimester abortions. Female partner reports showed abnormal values of antiphospholipid antibodies. Okay. So this is one sort of autoimmune disorder where repeatedly pregnancy rejection takes place because of the development of autoimmune system, okay, or an immune system which develops antibodies against self tissues, because fetus is a self tissue in the mother. And male partner has also showed the teratospermia. His number of or normal morphology of the sperm or the semen, it should be more than 4%. It is less than 4%. That is why teratospermia was there. This is one scenario. And the second scenario, a couple with 4 years of marital life complaining of 2 first trimester MTP, induced MTP due to missed abortions, where suddenly the cardiac activity stopped. Then we need to go for MTP. And the female was Rh negative and her beta 2 glycoprotein IgG was positive. Okay. So here I am going to giving you the diagnosis already with a suitable investigations. Okay. So to reduce the time, otherwise I have to tell the scenario and I have to tell the investigation name and the reports. So avoiding that much time, So I had directly added in the history only. A first case is autoimmune disorder of antiphospholipid antibody syndrome, and this is Rh incompatibility with beta 2 glycoprotein IgG syndrome. So this beta 2 glycoprotein is also one sort of autoimmune factor, a protein which is releasing in the maternal tissues, which blocks the trophoblastic arteries, where suddenly the baby does not get the proper nourishment from the mother, and the pregnancy failure will be there. Early pregnancy failure will happen. So in these two cases, what can be the clinical protocol we can follow as a Ayurveda specialist? Okay, so the best simple protocol here I'm telling you, that is the Garbha Samskara, a simple Punsavana Vidhi, where I had given Shodhana at the first trimester, so the first cycle, not trimester. In the first month, once the patient came, I had given them Shodhana first as a Bija Samskara for male and female, assessing their doshic levels. I had advised Panchakarma treatment for them. After Panchakarma treatment, in the next cycle, we started the treatment for fertility and the patient became pregnant. Okay. Sometimes the patient directly come with the UPT positive report. Then you have a task to maintain the pregnancy, continue up to the full term. So that time, this Garbha Samskara will give you very good result, where Punsavana Vidhi, most controversial topic in our Prasuti Tantra. We cannot use Punsavana Vidhi according to the PCPNDT, and regularly we are fighting and keeping the topic in the obstetric or Ayurveda Prasuti Tantra subject, even if the modern PCPNDT opposes to keep it as a Punsavana Vidhi. Why we kept this and what proof we had given? Because Punsavana is not only for the male baby, it is helping us to continue the pregnancy as a protection for Garbha. Okay. So I had given Garbha Samskara in all two cases, post conception, second month, and third month are exactly what we can say before completion of 12 weeks. Once the patient approaches to your hospital, how many times you get the Pushya Nakshatra before 12 weeks, all that time we have to go for Punsavana Vidhi. Okay. So the drugs which we use in the Punsavana are very simple and easily available. There is Ishwaralingi Bija and the Vatankura, that is the Vatashunga, then Gokshira, triturating and giving in the form of Nasya. So you know all about this. Why? This is helping in the protection and the prevention of abortion, because the property of Ishwarlingi Bija, you can see it contains bryonin and the bryonitin, which acts as a anabolic steroids for the development of new tissues, and also it helps the product maintenance of the HPY axis, where it increases the LH, helps for the aromatization of testosterone into estrogen, because you know estrogen is a main food for the maintenance of pregnancy in uterus. Okay, so throughout the pregnancy, estrogen level should be maintained high. It has a important role in the development of baby, preparation of uterus, preparation of cervix, and for the healthy develop or the normal delivery. Okay, so that is why maintenance of estrogen is very important, and that will be done by Ishwaralingi Bija. It helps for ovulation induction if you give Punsavana preconceptionally. It increases the endometrial thickness if you give Punsavana before pregnancy and after pregnancy also. If you increase the endometrial thickness, it is a best bed for the implantation, and proper implantation will prevent the future abortions. Then Vatashunga, it also contains all these things. It helps for the aromatization or maintenance of estrogen, and it affects on the CNS system to maintain the HPY axis. It helps in the ovulation induction. It increases the endometrial thickness. And the probable mode of action of Nasya, as we know, so it is a popular uh, picture where we are going to see many type of the presentation. So you know that Nasya, the drug, is going to Shringataka Marma, and through that it reaches the Shiras. Okay, Nasahi Shiraso Dwaram. So once it reaches to the Shiras, it is going to stimulate the HPO axis, where directly the HPO axis stimulate the GnRH. So vaguely, I'm not saying, if you go with the endocrinology, there hypothalamus has two types of the connection. One is within the brain and outside the brain. So within the brain means if you stimulate any area in the brain, directly the hypothalamus will respond. So like how if you give the nasya, if the drug stimulate any area in the brain, it is going to stimulate the hypothalamus. There is a GnRH secretion. So once the GnRH secretes, there is a secretion of FSH and LH from the pituitary, and they maintain the ovulation in the ovaries. Okay. So throughout it is a process where we are going to get the success in achieving pregnancy and maintenance of pregnancy. So that is why I chosen Garbha Samskara. Along with Garbha Samskara, oral medications which I had given, modern hormonal support was continued. Either oral or vaginal progesterone capsules was given 200 mg. Folic acid tablets were also given up to first trimester. Whenever the situation demanded, even IM injections of HCG and Maintain was also given. Okay. So only first trimester we had given the integrate approach. But once 12 weeks completed, no modern support was there. Completely the pregnancy was maintained with Ayurvedic protocol only. And the best Ayurvedic protocol which you can follow is Masanumasika Garbhasrava Chikitsa, mentioned in all classics. Okay, so 4 to 5 drugs for each month they had mentioned, and nowadays Arkashala and Gujarat pharmacies are directly they are preparing Masanumasika Garbha tablets. Okay, first month, second month, third month, like that. A tin 60 tablet or 90 tablet tin they will provide you, which is a best medicine to continue the pregnancy, especially in the cases of autoimmune disorders. Okay, so Garbha Samskara plus these oral medications, they avoided the chances of pregnancy, avoid the chances of abortion, and successfully they continued the pregnancy up to full term. And even we only delivered the two cases where modern failed to treat the case, and during pregnancy they referred low molecular heparin injections daily throughout the pregnancy, where that much cost is not beared by that couple. So they are very poor or low economic status people. For them, with this simple treatment, I had given them the positive result. This is a one example of adopting Ayurveda approach in a obstetric abortion topic. So you can avoid that thing. Okay. Then there is a second scenario where most untouched condition, that is a 23 years, had 5 second trimester termination of pregnancy due to IUD with the severe preeclampsia. Okay. So whenever the term preeclampsia comes, forget about the general practitioners. Even a Ayurveda gynecologist or a PTSR specialist, they will never touch preeclampsia in their practice. They refer this case to higher centers because it needs extensive observation and the management. Okay. So 5 times she lost her baby because of severe preeclampsia, and the IUD was happened. Okay. So I think there is no need to explain about the severe preeclampsia. So preeclampsia is a state where hypertension will be there, proteinuria will be there, edema will be there, and liver enzymes alteration will be there. Because of that, mother failed to supply proper nourishment to the baby, and continuously the baby feels hypoxia, and suddenly the IUD may happen. And also, because of storage of more and more hypertensive factors in the maternal vessels, mother is also severely affected she may go into coma also. That is why severe preeclampsia, usually very less number of people, they tackle preeclampsia in an Ayurvedic way. Okay. So here, another preeclamptic case example is there. A female aged 25 years, primi gravida, 22 weeks gestation, severe preeclampsia, headache, edema all over the body, including vulval edema is there. On examination on that day, BP was 180 bar 120, USG shown IUGR. Fortunately, there is no IUD now. IUGR was there. Loaded magnesium sulfate injection to termination. So the already the modern doctor given magnesium sulfate anticonvulsive therapy and referred for the termination. After taking injection, they changed their mind and came to Ayurveda hospital. So the previous one, previous history, this is the present history of preeclampsia. So what we have to do in such cases? Okay. So simple thing, so it is also another same example. I don't want to read this same PIH and IUGR case. So here, the first thing what we have to follow is Ashwasana. There is giving motivation and strength to the couple because already they distressed, disturbed because of preeclampsia and previous so many bad obstetric histories. Then another relaxation therapy is Padabhyanga. Oil, lukewarm oil should be applied daily, night and morning on the Pada. So it will relax her like a sedation, okay, a temporary minimal dose of sedation. So with the Padabhyanga, she will feel energy and she relaxes. And the third one is Siravyadha. Okay. So it is also followed in the OPD basis. Okay. Siraveda means there is no need of any special setup. Okay. You have to ask the patient to drink Yavagu or the rice grial ganji mixed with the ghee regularly for 2 days, and on the third day morning she have to drink again Yavagu with the ghee, and you have to do the Siravyadha. A simple 18 number cannula or a bigger SV set can be inserted in the cubital artery and leave as it is in the kidney tray. So the last next end should be kept slipped in the, or next end should be kept in the kidney tray. So around 40 to 50 ml of the blood comes out, and after certain minutes there is a drop wise blood and clot formation will be there in the next end of the SV set. So this is simple procedure. Siravyadha can control effectively the hypertension. Even you can give it to avoid the hypertension if she is already known case of preeclampsia in the previous history, or already the BP has been developed, hypertension developed in the present pregnancy. Then also you can use it as a therapeutic. Both preventive and therapeutic aspects you can use Siraveda. And there is no need of repetition of Siraveda every 15 day, 20 day, 1 month. So not like that. A single shot of Siraveda can control hypertension up to 6 months or more than 6 months. As you know, Siraveda is indicated in the Raktaja Vyadhis, right? So here, this hypertension is always Rakta Pradoshaja Vyadhi. The best treatment in Raktaja Vyadhi is Siraveda. So considering that nothing intelligency, I have to add in that whatever given in the text we had given. Okay. So Siraveda will effectively control the hypertension. And controlling hypertension is not only sufficient to maintain the pregnancy affected with the hypertension or the PIH. Okay. So there we need to balance the growth of the fetus also. Most of the time, IUGR is the common complication in PIH. Because of the narrowing of the vessels, mother cannot supply proper nourishment to fetus. That time, go for Tikta Kshiravasti for 8 days. Definitely it will give you miraculous results. Okay. Why I added this? Because the Tikta Kshiravasti, You should have a gas connection in your OPD. Simple, that is sufficient. 100 ml milk, 25 gram st madhu churna, 25 gram kokshura churna, and 400 ml of 200 ml of water. Boil and reduce up to 100 ml, and filter. That 100 ml should be given basti. So 100 ml glycerin syringe is available. There is no need of sterilization. So simply you can push the Shira in the basti. So or enema, you can give the enema. So that is how Tiktak Shiravasti, if you give 8 days, it is effectively controls the hypertension, all constricted vessels, it induces the vasodilatation, and it nourishes the fetal weight. And I had seen with the 8 days of Chiravasti, minimum 200 to 250 grams of the fetal weight increases, especially in the later trimesters, more than 30 weeks onwards. If you give Chiravasti, it is effectively going to increase the fetal weight more than 200 grams within that 8 days. And that to healthy weight gain, no side effects to fetus and the pregnancy. So that is why Siravyadha, Padabhyanga, Tiktakshiravasti. If you follow it in your OPDs, effectively you can control preeclampsia. Okay? You can give more better results than modern if you follow this protocol. And curiously, you may ask what oral medicine I had given. I had given Cardorium plus syrup. Ready-made it is available in the market. And the Kshirapaka of ST Madhu and Gokshura. Whatever the Tiktak Kshira Basti we are giving, the same Kshirapaka 50 ml morning, 50 ml evening. Orally also I had given. Okay. And sometimes if she have a severe preeclampsia, like the second scenario what I explained, she already developed hypertension and she was on modern medication, then she approaches to Ayurveda. So labetalol 100 mg, which was prescribed by his previous doctor, was continued according to the same prescription. We had continued. Once BP settled, we reduced the modern labetalol tablets. Okay. So in all these two cases, we got a very successful result. This is a live case sheet of my hospital. You can see the previous history. 1, 2. The first one was PIH. Second, she suffered from GDM. Third was again PIH. And fourth pregnancy, at the time of examination, it was 160/100. And she was ready to terminate the pregnancy. And I told her, wait for 2 days, get the Siraveda done. Once the Siraveda over, then you think about termination. So we did Siraveda in our hospital. Soon after that, her BP settled to 130/80, and it was continued till the full term. Never she suffered from hypertension throughout her pregnancy. But only one thing you need to consider, I had given Cardocalm tablet 1 BD. Here first 1 TID, then reduced to 1 BD throughout the pregnancy, which balanced her hypertension. And in all these three cases, baby with normal weight more than 2.5 kg delivered at full term without any complications, except that second case where already the anticonvulsive therapy was loaded. So that baby delivered prematurely. Female baby was there, and her baby weight was almost 1.3 or 1.4 kg in Gadag. She delivered, and the baby was quite normal. After NSU management, still today the baby is normal. Okay. So like this, we can definitely control the PIH in our OPD levels. If I tell, I can give all type of examples, all type of disorder management in Ayurveda. But due to time limitation, I covered very important cases where repeatedly you may get in your OPDs. Then it comes the Garbhini Makkala. It is nothing but the premature contractions, okay, or a false pain generally we tell. Okay. So sometimes the patient may come up with the stiffness of the abdomen, white discharge, and severe pain before labor, that is before 34 weeks of gestation. So if before 34 weeks, anytime severe pain is there and low back is there, we call it as premature contraction or a irritable uterus. Okay, so that is nothing but the Garbhini Makkala in our classics. Okay, so here 34 years patient, E1, L1, A0 history, 30 weeks of gestation, previous history of preterm IUGR delivery. She came up with the severe cramping in back, spasmodic abdominal pain, low back ache. Okay. So on examination, we came to know it is a irritable uterus. Once you keep palm on the uterus, you will feel alternate tightening and softening. So it indicates you irritable uterus. And we did the pervaginal examination. Fortunately, there is no dilatation and effacement of cervix. Okay, there is no starting up of the labor process. Only contractions were there. Okay. So then a simple management, again the Ashwasana was given and Anuvasana Vasti with Sahacharadi Taila 80 ml for 5 days I had given. She went to SDM Dharwad. She stayed for 3 days there and continuously the Duodilon injection was infused. Duodilon 40 mg SR tablet was given. On discharge, once she came back within 24 hours, again she started pains. But after that, I had given Anuvasana Vasti with Sahacharadi Taila for 5 days. You have to believe that she never suffered pain throughout her pregnancy because the previous pregnancy was LSCS. Now we took elective LSCS in the second time, and after 38 weeks of gestation, a male baby of 3 kg she delivered. Okay. So this is the simple management because Makkala is because of Vata Apanavayu Vikriti. In Apanavayu Vikriti, Anuvasana or Sneha Basti helps more. Keeping that aspect in the mind, Anuvasana Basti was given. There is Vatanulomana, Brahmana. Because of that, there is no pain and baby development is also normal. In that way, this Anuvasana Vasti managed the premature contractions. Okay. After that, I had treated so many cases where now, I don't prefer Duodilon in my hospital. If a patient comes with premature contractions, I will give Matravasti or Anvasanavasti. It is giving more better results than modern protocols. And if you want to give oral medications, you can add Vatakulanta Karasa and Yashti Madhu Kshirapaka. So it will help for the control of pain and also help for the growth of the fetus. With this simple 2 or 3 examples, I am going to wind up the obstetric exposure or obstetric Ayurveda management. These are some of the evidence-based promising drugs which I use in my hospital for prevention of abortion. These much drugs, Garbhini Chardi, these all the drugs, antispasmodics, these all the drugs. Because of time short duration, I am not reading. So I will forward my PPT to organizers so that you can share in your mobiles. Everyone can see what all the drugs I had given. Then these are the Ayurvedic iron and calcium supplements. And I can proudly tell that starting from the day one practice till today, I never use modern iron and calcium in my hospital. I use only Ayurveda. Blood thinners, I never use Ecosprin in my practice. I use only Cardorium Plus or Hridaya Shanti, Hridayaranavaras, or nowadays another one, so many other Arjuna Aristas also you can use. These are the best blood thinners, and another best blood thinner is Drakshasava. You can use that. They are giving very good result than Ecosprin. And Sukha Prasavakara yogas. So many people they ask for normal delivery. For them, you can tell them to take these gritas once she completes her 34 weeks or 36 weeks. Okay. Once she completes 36 weeks, after that, she can take these drugs daily. Okay. So I think
Sorry to
the
interrupt,
three
sir, for
examples.
constipation, sir.
Madam, constipation is also coming under Garbhini Makkala. You have to use Matra Basti in that case. If you want to give oral management, I prefer to give Sukumara Grita because pregnancy constipation is mainly Apanavayu Vikriti, which is going to dry up her intestinal motility. Our intestinal environment will be completely dried up. We need to regenerate the intestinal motility and we need to reconstruct the intestinal activities. So you need to give gritas compulsorily, either orally or matra basti. Even the constipation same will continue in sutika period also. There also basti chikitsa is best than oral treatment. Okay.
So
So
dosage
only
for
the thing
Sukwara
is,
Grita, sir?
madam, 20 ml morning, 20 ml night with milk before food.
Thank you, sir.
Yes, ma'am. Okay. So next we will come into the approach in Stri Rogas. Okay. So this is just for the brushing up of your knowledge previous. There are four nidanas they told: Mithyachara Tahastrinam, Pradushtartava, Bijadosha, and Daiva. Four types of Samanya nidanas they mentioned, and these are the division of yoni vapats according to the nidanas. Okay. So mithyacharajanya yoni vapats are vataja, pittaja, kafaja, so and so. I'm not going to read this. It is for your home, like a assign, like a notes purpose. I will share you the PPT. You can read it. Yoni vapat due to improper coitus, that is the mithya achara, ahara, both. Then pradushta artavajanya yoni vapats are these. Bija dosha jivani vapatar, Shandi and Suchimukhi. Daiva Karanajanya Yoni Rogas, all Yoni Vapats are because of Daiva Karanajanya, because of Purva Janmakrita Papa Karmas only. Vishishta Nidanas, where we are going to come across, because you are going to see these Yoni Vapats. Once I want to say that the first thing, complete gynecology is nothing but yoni vapats. If you read and if you become expert to treat all yoni vapats, then any disease you are going to treat, because most of the gynecological disorders are resembling with these 20 names only. Okay, so everything can be included in this 20 names only. Okay. So one is prasramsani yoni vapat, duk prasuta janya. So if labor management is not done properly, okay, if mismanagement done at the time of normal labor, definitely prolapse will happen in future. Then akale vahamanaya, if there is no full dilatation of the cervix and if the head is still more, it is still in the +1 or +2 station, that is away from the crowning period, that time unknowingly if the patient's attender or ayas, they tell her to give the straining or intra-abdominal pressure so that the delivery will become faster. So it is a wrong thing. Before dilatation of cervix, if we advise her to go for straining, then definitely it is going to cause cervical damage. In future, she may suffer from Karnini Yonivapats. Very practically they told. Okay. If any cases of cervical erosion comes to your hospital, then definitely you have to take the history of previous obstetric things. Most of the patients, they tell you there is a difficulty in previous labors. Then Upapluta, there is Chardi and Nishwasa Vega Dharana. So if Garbhini controls her with the Chardi, because Chardi we know that it is a common symptom in the first trimester. If she controls that, there is Upapluta Yonivapat in future life. Like that, Kshavatu and Udgara Vega Dharana, leading to Paripluta. Okay. So these are all the things we are going to see as special nidanas. Okay. So just these slides are for brushing up of your previous knowledge. Then how to consider yoni vapat with the modern gynecological conditions. Each and everything we had correlated here. Vataja means endometriosis, acharana means pruritus vulvae. All types of disorders are there. Infectious conditions, and discharges, abnormal discharges, purulent discharges, offensive smell discharges, PID, then prolapse, itching, all types of varieties we have considered here. Okay. So these are 20 yoni vapors with the modern correlations. So then there is a special in continuation to the previous one, that is Mahayoni Vapat, third degree Yoni prolapse, and Prasramsini, second degree Yoni Vapat. So here I want to give a beautiful evidence based protocol where you can practice it in your OPDs, but only the thing is you should have Panchakarma setup or a separate private room for the procedure. The best one is Veshavara Bandha. So where we are going to use Shunti,
ಹೋಗ್ಯಾರಲ್ಲ ಅವ್ರು ಇಲ್ಲಿದಾರ
Maricha, Krishna,
ಬಂದಿರ್ತಾರೆ
Dhanyaka, Ajaji, Dadima, and Pippalimala. All
ವಾಟರ್
easily
ಬಾಟಲ್
available drugs. And Ajamamsa is needed. Okay. So we need to fry the Ajamamsa in ghee, add the churnas of all this.
ರಾತ್ರಿ ಮತ್ತೆ ಬೇಕಂತಂದ್ರೆ ಇದಿರ್ಲಿ
I think
Sorry to
somebody.
interrupt, sir. Basavaraj, mute your
ಹಾ
mic. Basavaraj, mute your mic.
Okay. Yes. So with this drugs, we need to prepare a bolus, a small shaped bolus, which should be kept in the cervix, which should be kept in the vagina. This will give you very beautiful results rather than pessary insertion. Okay. It is best way or a best alternative way. We cannot say alternative, it is the best way. Pessary is the alternative way. Okay. So this is the best way of approach in second degree prolapse. Okay. So you can see the preparation of method. So we had fried the ajamamsa, mixed the churna, and we make it in a bolus form, and it is tied in a thin gauze piece, and that gauze piece was inserted. Before insertion, we had given local abhyanga with the ghee, and Svedana was given. Once Svedana was done, the prolapsed uterus pushed inside, then this Veshavara Bandha is kept inside the, and T-shape Gofana bandage was done, and the bandage was allowed there itself, and the pichu was kept there itself for the next 1 or 2 hours until she gets the urge to micturition. Okay. Once she get urge to micturate, then we told her to remove the pichu or that cotton, then Gofana Bandha can be removed. So like this, we did the procedure for 8 days. Okay. So you can see the prolapsed cervix here, second degree prolapse. So completely, even if she is not cuffing, that much amount of cervix is came out. So we did the abhyanga. It is the abhyanga procedure, and then after abhyanga, we inserted the cervix inner side. Okay. After this, we kept the bolus, that is the Veshavara, tightly inside the. Yes. So after this, Gofana Bandha, making a T-shaped bandage. So we tied Veshavara with Gofana Bandha, made up of gauze only. Yes, like this, Veshavara Bandha should be tied, Gofana Bandha, and ask her to sleep on the bed until she gets the urge for next micturition. Or she can go to home and continue her day-to-day activities. Once she have urge to micturate, then she have to open the Gofana Bandha and remove the bolus. Okay. So this simple Veshavara Bandha for 8 days will give better results than pessary and avoid the chances of hysterectomy. So we are going to see nowadays most of the people, they undergo hysterectomy before 40 years, which is very pathetic condition to manage, because before 40 years if you insist for hysterectomy, she will have lot of syndromes after hysterectomy. That is a post hysterectomy. So she will have maximum menopausal syndrome. 48 symptoms of menopausal syndrome may appear in her, and it will be very difficult to manage. Okay, so that is why this Veshavara Bandha will give best results in the management. Only the thing is, you have to handle the ajamamsa, whether you are a vegetarian or non-vegetarian, without hesitation. You have to prepare that, and a bolus should be kept inside. Okay, so after that you can go and take a bath if you are not a non-vegetarian. If you are a pure vegetarian, you can take bath after that, but do not hesitate to give the treatment. That is my intention, right? So next we will enter into the most important topic everyone want to hear, that is the practical approach in a female infertility. Okay, so these are the causes of infertility: anovulation, the ovarian factors, tubal factors, endocrinal factors, male factor, and other factors are there. Here I am going to give you examples with each and every factor. The first is ovarian factor, where 30 to 40% of infertility couple or infertility female is suffering with the ovulatory factors only, which include anovulation or oligovulation, decreased ovarian reserve. Nowadays you are going to see so many cases with decreased ovarian reserve, or an alternative, low AMH, low anti-Mullerian hormone patients, where low AMH is a, nowadays it is a business, where if you are low AMH, go for IVF management. There is no scope of normal fertility. Okay, so mostly the cases are turning to IVF treatment only. Okay. Then the luteal phase defect, luteinized unruptured follicle, these are ovarian factors. The first one which I tried is Jeerakadi Taila, and I had published an article in the year of 2000, I think 2006 or 2013 or 14. So that time we had prepared this Jeerakadi Taila. It is my own formula. There is nothing special mind I added in that. All drugs which are famous in treatment of infertility, that I added in this Taila. You can see it is consisting of 6 ingredients: Krishna Tila, Krishna Jeeraka, Shatapushpa, Lashuna, Vidarikanda, Shatavari. All 6 drugs indicated individually and proven best infertility management drugs individually. So all 6 I added and prepared Taila with Murchita Tila Taila. How I used this? For 3 consecutive menstrual cycle, 10 to 15 ml BD with Kshira. Orally, I had given Shira and Sharkara, okay, before food. 10 to 15 ml BD before food, daily for 3 consecutive cycles I had given. And I asked the patient to come on day 3 to get the medicine, and for the baseline scan, how the status of ovaries at the present cycle, that we have to see. The present month, how our ovaries are responding. To see that, baseline scan was done. Then day 10th onwards, serial follicular study was done till ovulation. No letrozole, no clomiphene citrate, no any other drugs were given during this pilot study. So this was repeated for 3 consecutive cycles, and after treatment without drug, we observed for another 1 cycles. So around here, around 20 patients were added in this study, in this pilot study, and all 20 patients previously no dominant follicle. They are having no dominant follicle, and at the cycle and during the treatment, we had seen their cycle lengths were also altered, and it came to normal, and all 20 patients are ovulated. Okay, so but you can ask why n equal to 24 after treatment. n equal to 20 before treatment. What about these six numbers? Okay, so these six patients are conceived on the very first cycle only. Okay, so keeping that aspect, remaining 14 members are also, they have attained the normal cycle interval 28 to 34 days, and cycle length was also normal, and all, you can see after treatment all 14 patients are having more than 18 of follicles. So that is, ovulation was 100%. Because of ovulation, her cycle length was also maintained 100%, and among that, there is 30% positive result in the pregnancy. So, with this simple Jirakadi Taila, for 3 cycles, you can give better results for the conception. Like that, what I told you, low AMH or a low ovarian reserve, the best medicine which you get in the market or you can prepare yourself only, that is the Jyotish Matyadi Kalka mentioned in Bhava Prakasha. So even a thesis was prepared in my college. My student uh, completed a thesis on Nashtartava. So the ingredients are very simple. Asana or Bijakatwak, Sarjikshara, Vacha and Jyotishmati. Only 4 drugs. That to Jyotishmati Patra, not other parts. Jyotishmati Patra. Only with these 4 ingredients, we had achieved so many n number of pregnancy. I avoid to use letrozole and clomiphene citrate. Maximum cases we give Jyotish Matyadi Kalka or Jyotish Matyadi Churna only. Okay, you can see a live example. So we had started treatment from 9/18/2019, where Jyotish Matyadi Kalka was given. You can see the right and left follicular size. So a good quality follicle was there and ruptured also. HCG was given to rupture. Then some medicines were given to maintain. Okay. And the same case, again Jyotish Matyadi Kalka was repeated, started on the, you can see 9/12/19, and treatment was ended 6/1/2020 and 24/4/2000. So that is around 4 plus 1. 5 months treatment was given with the Jyotish Matyadi Kalka, and finally amenorrhea of 34 days and UPT positive was there. Okay. So you can see UPT was positive in the same patient, right? So with this 4 to 5 months of Jyotish Matyadi Kalka, you can achieve best results rather than giving modern medicine. Even if you give letrozole also, patient needs 6 months. Even if you give Jyotish Mati, patient needs 6 months. But the positive benefit is Jyotish Mati not only helps for ovulation, but also helps for endometrial thickness and also helps for proper implantation. It is a multi-directional drug, but where the letrozole only single direction drug. It will help ovulation, not other factors will be covered in that. That is why Jyotish Matyadi Kalka is a best drug where you can use it as an alternative to the modern ovulation stimulation drugs. And the next one is a most popular, nowadays popular thing is low AMH. Okay. So what we have to do in the low AMH, which drugs we have to give? So many patients will come and ask you, sir, with Ayurveda, AMH will increase. So you give the drugs which can increase the AMH. So where most of the our practitioners, they use Pushpadano Rasa, Stri Vyadihari Rasa, then the ovarian capsule, so many other patent drugs to increase the AMH. But one thing I want to say here, AMH is the hormone which releases from the antral follicles, which is a fixed value. You never alter the value of AMH with your treatment. Only the thing is, you can improvise the quality of ovum which is going to release with the Ayurveda modality. So as simple as I can say you, what is low AMH? AMH, low AMH is nothing but there are 2 categories of the students in a classroom. One category, intelligent category. Another one category, dull category. Both the student will pass at the end, but the thing is, for intelligent, you need to tell once or twice. But for poor student or a dull student, you need to repeat the same procedure for 6 to 7 times. You need to give assignment, homework, so many other exclusive treatment should be given if you want to pass that dull student. Same here, if a low AMH patient is there, you need to give more attempt for the conception. That's it. That is nothing but the patients should be there for a doctor and patient both. So if you give time, definitely low AMH patient can achieve the pregnancy. And here I can say that 0.11, 0.07, 0.03, that much amount of AMH patients were also conceived in my hospital normally without IUI, without IVF. Okay. The best treatment is Matra Basti. Okay. You can use 60 to 80 ml of Matra Basti with Mahanarayana Taila continuously for 8 days, starting from the day 5th of cycle, and give them proper dates for conception, day 10, 12, 14, 16, 18, like that. Okay. So if you tell them to go for coitus on that particular days with Matra Basti, then the result is very good. And where is the reference of Basti? Here in Kashyapa Samhita, Nashtartava, Nashtabija, Anuvasayet. In these two conditions, Anuvasana Basti is the best method. If Anuvasana Vasti you want to give, 100 ml oil should be pushed. It is very difficult. Some people, some patients may not tolerate that much amount of sneha. So the lowest dose of Anuvasana Vasti is Matra Vasti. So we had given 50 to 60 ml. Okay. You can see I had given Matra Vasti with Mahanarayana Taila 60 ml for 8 days. 10 cases regained their normal menstruation from first day of cycle only, with good follicular response, spontaneous development of dominant follicle, and rupture at appropriate time. And at the end of this study, now it is more number, but once this PPT was prepared, among 10 cases, 3 cases conceived naturally on the third cycle. So not only in the first cycle, 3 to 4 cycles they will take time to conceive. Okay. So that is how Mahanarayana Taila Matra Vasti, which can be practiced at the OPD level, will give you very beautiful results. Then you know that tubal factors, main is tubal blockage. Okay. So in tubal blockage, my protocol is 5th day, 6th day, that is soon after cessation of menses. 5, 6, 7 day I had given Uttarabasti, 8, 9, 10th day rest, 11, 12, 13th day Uttarabasti again. The same 6 days protocol was followed for 3 consecutive menstrual cycles. And the oil you can choose is Sahacharadi Taila, Kshara Taila, Kasisadi Taila, Jatyadi Taila, any drug according to the condition you can choose. So this Uttaravasti is a very best gift to a Ayurveda physician, where you can achieve so many miraculous results with the Uttaravasti. Okay. And one thing is, I never use any sedatives. I never use any type of the analgesics drugs during the Uttaravasti. Okay. So I give simple, I follow the classical method of Uttaravasti, where Snehana Svedana was given. After that, Uttaravasti will be given, and patient is allowed to lie down for 15 to 20 minutes on the bed. And during that, slowly abdominal massage was given. The same method will be followed. And oral medication in tubal blockage I prefer is Chandaprabhavati, Saptasara Kashaya, and Gynocare patent capsule. So other drugs you can prescribe. It is my idea. Okay. So this is the Uttaravasti procedure. Because of shortage of time, here I am not going to show the total procedure. So you might be seeing in YouTube's also. So this is the case before treatment. She is from Jamkhandi. She came all over to Kopal. You can see one tube is visible, but peripheral ovaries are not visible. So partial blockage. Here only the blockage is there, corneal blockage. At her the right side, left side, complete blockage, right side partial blockage was there. And the same protocol was given. You can see after treatment, complete tube you are going to recognize clearly right and left. And this is nothing but the oil spilled at the peritoneal end also. Peritoneal spillage is also there. So her blocks were completely opened. After that 2 months, she conceived naturally, and in couple only we delivered her a beautiful female baby. So this is only one example. Like this, so many other examples are there. And some of the uterine factors are also there. Generally, a thin endometrium. Sir, I took treatment from modern hospital. Sir has been told to increase the endometrium thickness and come back. So whatever the drugs they are giving, endometrium thickness is not happening. Endometrius is below 5 mm only I am getting regularly. So because of that, I am unable to conceive. Like that, some complaints will be there to the patients most oftenly nowadays, because they use HMG injection, letrozole liberally in the hospital for 3 to 4 cycles. As a side effect, endometrial hypoplasia will be there. So what should be done in that case? We did a thesis on this. You can see very simple drug Ashwagandha Grita was given, and it was compared with the modern estradiol valrate tablet. We had seen the results of both. Okay, and you cannot believe that Ashwagandha Grita shown more better results than the estradiol valrate, not only in the thickening of endometrium but also for the proper implantation. Estradiol valrate help for endometrial thickening, but the rate of implantation is less in comparison to the Ashwagandha Grita. So oral Ashwagandha Grita 20 ml morning, 20 ml night with milk before food I had given in such 30 cases of thesis. All cases they shown improvement in the endometrium thickness, and among them more and more number of cases they came up with the UPT positive results because of proper implantation. Okay, so that is also one of the thing. And how to manage the uterine fibroids nowadays? It is a big headache. 25-26 year females or also young age female also, they approach hospital with the complaint of uterine fibroids, and the first tension of patient is whether that fibroid is going to convert as cancer or not. Okay, definitely fibroids will never convert into malignancy. They are benign tumors only. If you manage it properly, it will not grow, and there is chances of reduction in the size with the extensive treatment. How to manage this case? This is a live case we had given. So you can see mildly bulky multiple fibroids, 6 to 8 intramural subserosal fibroids. Among them, 2.7 into 1.8 is the largest. Okay, so this is the present status, and AMH was 0.19. And the treatment was given Matravasti 2 days. Third day Matravasti plus Uttaravasti was given. Fourth day plain Matravasti. Fifth day Matravasti with Uttaravasti. Like this, 8 days treatment was planned. Okay, and after this next cycle we did not follow this protocol directly. Only Uttaravasti was given with Arbudahara Taila. So this is the special Taila mentioned in Sahasra Yogam. You need to prepare that. There is no market available. Arbudahara Taila is available. So it is not available in the market. We need to prepare by own. So I had prepared Arbudahara Taila, and the same Uttaravasti was given for 3 consecutive cycles. After that 3 consecutive cycles, you can see anterior wall at least 4 fibroids. Previously, it was 6 to 8. 4 fibroids were there at the anterior wall, and at the posterior, 4 fibroids were there, and endometrial lining is also proper. Previously, endometrial lining is completely distorted, and that is why we managed this case. And this is 2021 report. At the year of 2024, she conceived naturally, and now she had a female baby. Okay, so after 3 years she conceived because it takes more time to resolve the fibroids. Once the fibroid size will reduce, then the endometrium lining will form properly, and once the endometrium line will form, then you have to give for ovulation induction and attempt for fertility. So at least this case took 3 years time to conceive. And the last one is cervical factor. So it is very like what we can say unexpected factor. Okay, we ignore this factor. Okay, so a couple with 6 years of primary infertility, all reports were normal. They took modern treatment in many hospitals but failed to conceive. Even I too tested, all reports were normal. So I thought that we have to go for checking of cervical factor. I did post-coital test. So what is post-coital test? You have to call the patient or the couple. It is very awkward test exactly, but we need to convince the couple. You have to call the patient in hospital. We need to arrange them the privacy, and they have to undergo coitus there itself. After coitus, she should not wash her genitalia. We have to take sample from posterior fornix and the cervix and test it on the microscope. 3 times we need to take the sample, 15 minutes after coitus, 1 hour after coitus, and third or fourth hour after coitus. All 4 hours, once you take the sample, the sperm should be live in the microscope. If the sperm is not live, then the problem is with the cervix. Cervix will have anti-sperm antibodies, okay, anti-sperm antibodies, or there may be some sort of infections which are blocking the travel or entry of the sperm inside the cervix. They make a mechanical barrier. Because of that, sperm fail to cross the cervix. Even if they undergo 3 to 4 times in a week coitus, there is no result at all. Okay, so this case revealed cervicitis and presence of sperm antibodies. So what is the process? The thing is to bypass the cervix. I did the intrauterine insemination of husband sperm, okay, semen. So we chosen to bypass the cervix and we went for IUI. In that cycle, in the very first cycle, she conceived normally, and finally she delivered a live male baby. The same case, another in the second case, here the IUI was done for 3 cycles. On the third cycle, she conceived naturally, and fortunately, luckily, she delivered twin female babies normally. There is no section. We delivered twin male normally. Then atresia of vagina. So nowadays, the patient will come up with the dyspareunia, painful, that is painful coitus. So most of the time, if you are a female doctor, if you are a male doctor, you may not get or you may never get such cases in your OPD because it is most too personal factor. The female can open up with this complaint to only a female doctor only. Okay, so that is why the vaginal factors are rarely seen in a male OPDs. This atresia of vagina or partial septum of the vagina are mainly vaginal factors. Okay, so what type of case I got is with 4 years of marital life, dyspareunia was there, and doctor already told there is no consumption of marriage. Her hymen is still intact. Doctor said that. But we did the PV examination. The introitus vaginal opening was very narrow, where we can admit a tip of finger only, not 2 fingers, tip of single finger I can admit. That too severe pain she is having, but her hymen was ruptured. We had seen partially ruptured. Okay. So in that case, modern people, they told to go for vaginoplasty. So what we will do in vaginoplasty, introitus at the lateral, like 5 o'clock and 7 o'clock position, we give 1 centimeter incision, we widen the opening and we do the suturing at the tip. Inner, the opening will be like that only. So it will increase the diameter of the vagina so that they can go for proper coitus without pain. This is the concept of vaginoplasty. But here, if you go for vaginoplasty, we know that after delivery, normally the vagina will become lax. Okay? A loose tone will be there. So that time, unfortunately, she may lose her permanent sexual life because of over laxity of the vagina. So keeping that point in mind, they avoided or they refused to go for vaginoplasty and they came to my hospital. So what I did here, I did yoni purana. So oil, you know that oil is having muscle strengthening property, and if you apply the oil, stretching of the muscle will be there without pain. So it improves the extensibility and strength to the muscle. So that is why I did Yoni Purana of Balashwagandha Taila for 8 days. What we have to do? Allow the patient to sleep in a lithotomy position, take a 10 ml syringe, lukewarm oil of Balashwagandha Taila. That lukewarm oil, slowly we have to instill inside the vagina. Once vagina is filled with the oil, outside introitus, tightly pack it with the gauze and tell her to sleep for 45 minutes. Once after 45 minutes, you have to go to the bathroom, remove the gauze piece, drain out all the oil. She can wash her genitalia and go back. So this procedure was given for 8 days. Okay. On third day, I had inserted sim speculum without pain. On eighth day, we inserted cusco speculum without pain, and all direction we rotated the cusco speculum. She was not at all having the pain at least. And after treatment, we told her to only one cycle treatment I had given. It is not a repeated cycle, repeated treatment. Only in one cycle, 8 days, we had given the Balashwagandha Taila Yoni Purana. Then we told her to go for coitus regularly in the upcoming months. So on the fourth cycle, she conceived and finally she delivered live female baby, that too vaginally. Normal delivery was there. Okay. So simple consideration or remembering of the properties of taila and usage of such taila in yoni purana will definitely avoid the chance of vaginoplasty, and in future also it will restore the vaginal tone. Nowadays the many cosmetic surgeries are there, so vaginal tightening therapies are coming now. So many hospitals, they write it on their boards, cosmetic surgeries, where we maintain the or we do the vaginal tightening operations. Okay. So it is to avoid the future sexual disturbances. Okay. So in that case, rather than going to that procedures, yoni purana is very much beneficial. Okay. So there are still so many examples I'm having. Whenever the time is there, we will have a detailed discussion. So now I will conclude my session. Ekam shastriyam adhiyano na vidyat shastra nishchayam tasmat bahushrutah shastram vijaniya chikitsakaha. Never depend upon only one shastra. You need to read all contemporary sciences, then come to a conclusion how to treat the case. So once you come to that conclusion, no, you will be considered as a vijaniyat chikitsakaha. You will be considered as a best doctor. Okay. Then vak saushtave artha vignane pragalbhye karma naipune. So a doctor should have vak saushtava. You should have a convincing bonding type of the vocabulary, where you should have a proper attachment with the couples so that they can open up and they can tell their personal problems, which will be helping for you to frame the treatment protocol. Okay. Artha Vijnane, that is, you have to understand the Samhitas, analyze the Samhitas in a proper way. Pragalbhya Karma Naipune. Pragalbhya is a strong karma naipuna, that you should be well versed with the surgical procedures. Tad abhyasecha siddhav. With this, repeated abhyasa etena adhyayana antagaha. So repeatedly if you follow this, then you will become wise in the shastra. So this is how we follow, or there is no shortcut for achieving success. We need to follow these samhita words properly, adopt this samhita word in our life, so that we can achieve best success in our clinical practice. And finally, the key of success, especially in PTSR practice, is maybe it is OPD level, maybe it is operating level. Give more time to history taking and be patient to listen all complaints of couple. You should not cut in between the words of the couple. Be patient to listen all complaints of couple and motivate them every time, every visit to all patients. Because if it is a general complaint like cough, cold, and fever, or even diarrhea, or even typhoid fever, you can treat and give the result within 1 week. But if it is a PTSR case, you have to hold the patient, motivate the patient a minimum up to 1 year. Okay, up to 1 year, the patient should have follow up with you. Then only you can give best result to that couple. Is it right? So that is why give more time and be patient and take proper history, give minimum medicines, use minimum treatment protocols, so that each and every protocol should give multi-directional action which can cover all her aspects to maintain the pregnancy. Okay, so these words, so I conclude my session. Thank you very much for patient hearing. So if I took